Well, welcome everyone from the Arctic to the Antarctic to this presentation of conversations with OSS about COVID-19 plus more. With me are Emily Shore, who is our communications director, and Jonathan Jerry, who of course writes for us and you see him on videos. And our special guest today is Dr. Don Sheppard, who's a professor of medicine here at McGill and is the director of the Interdisciplinary Initiative on Infection and Immunity, MI4. Sounds like some British Secret Service agency. So Don, welcome to this. And I mean, obviously on everyone's mind is the vaccine regimen, whether to be happy with distributing one dose to more people, or whether we should be making sure that we're all getting it at the 21 or 28 day separation. So in Quebec here right now, we have a situation where there just doesn't seem to be enough vaccine. And the government is actually suggesting giving a single dose and then waiting around for the second dose. So let's start with getting your opinion on this.
Well, I think there's two big pieces to this. The first is, why do we have a second dose? What do the two doses do, and understanding that? And then the second piece is looking at the data that we have that can actually help us make this decision. So let's break that down. Let's just start with Vaccine 101, an intro to vaccines. Perfect. So your first dose, we take a chunk of the virus, in this case the RNA, we inject it into your arm, and what that does is it wakes up your immune system. It's a call to arms that tells your immune system, hey, heads up, something's coming your way, it's bad, you better get ready, and think of it as activating the emergency responders, right? So you got your first wave of defenses woken up, ready to go, and your body starts to make antibodies, and it activates immune cells. That's dose one. So then what does dose two do? Dose two is where we refine the response. It's like telling your body, okay, we're really, really serious about this. Now, let's not just get everybody on board. Let's actually make some specialists. Let's get some cells that are really 100% dedicated to this particular virus. Let's take those antibodies you make, let's fine tune them, and let's make sure that they are the highest quality possible. And let's keep everything around for the long term, because this is a real threat. So the second dose, it improves the quality of our response, and it improves the duration of the response. But it's often not necessary for us to be protected. Our emergency response team that we activate with dose one is usually enough to deal with many pathogens.
Now, how did Pfizer and Moderna arrive at the 21 and 28 day regimen?
Well, we scientists don't like to say we guess, but that kind of is the bottom line. So you give the initial doses in small scale tests, you see when people's antibodies go up, and then you actually ask some real world questions. You say to yourself, hey, we're in the middle of a worldwide pandemic, and if I do a trial where my second dose is going to be at month 3, and I have to follow people for 3 more months after that, I can't close my trial for 6 months, and I can't get my vaccine out for 6 months. So it's a balance in deciding when you're going to give the boost. And in fact, this 21, 28 day boost is actually very early in sort of vaccine speak, and we usually go later than that. The other little secret is that if you actually look at studies of many, many different types of vaccines, the timing of the second dose turns out to not be very critical. And there's studies showing that for many vaccines, you can mess around with that with a 1-year spread, and it makes no difference on the actual response to the vaccine. So that's sort of the background of where people chose the dose and why there's a sense of flexibility around, can we change the timing?
But I guess
the numbers that we have seen are 52% after 10 days, over 80% after 20 days from the first dose. What do those numbers really mean?
Yeah, this is the great debate, right? The 50 versus 90% number that everybody tells you the first dose does. Well, it's all about the science, and it's all about how you count. So the 50% number is how much protection you get from the second you walk out of the vaccine clinic with your sore arm until the time of the second dose, 21 or 28 days, depending on the Pfizer or Moderna. The 90% number counts starting at 2 weeks after you got the dose. So why 2 weeks? Doesn't that seem like a bit of a strange thing that we randomly say we don't care what happens for the first 14 days? Well, it's actually very logical if you understand how vaccines work. And the analogy I like to use here is training. So it's been COVID for a long time. We've all binged Netflix, and many of us have binged on food while we watch Netflix, and we have the famous COVID-19 around our waists. So we want to get rid of that. You want to get rid of that? What do? You call up a personal trainer, you set up a Zoom training session, you do the whole first workout, you get out of bed the next morning, and you can't move your arm because it's so sore, just like after you got the vaccine. And you step on the scale, and let me ask you, Joe, what do you expect that scale to say? Did you lose your 19 pounds?
I don't think so.
Training doesn't happen overnight.
If they look for quick fixes, that would be nice.
Yeah, I'd love that, but it hasn't worked for me yet, I'll tell you.
Yeah.
But so, it takes us 4 to 6 weeks to train our bodies. Well, vaccines train your immune system. But I got good news for you. Your immune system is better than your muscles. It trains in 14 days in the case of this vaccine. And when you look at those Pfizer and Moderna trials, the vaccine had no protection, 0, until day 12 to 14, which is exactly what you'd expect. That's how long it takes to make all of those first line defenders I told you about that can defend against the virus. So counting the efficacy of the vaccine should not start until 14 days. And so the 90% number is a much more reasonable one.
So people should still get their first vaccine, and then they literally act like nothing has happened. Like they should be doing social distancing and face masks, and not all of a sudden, taking one for the team and like going into the grocery store perusing at Winners forever.
No, the time to go to a rave is not in the first 14 days after you've had the COVID-19 vaccine. Let's be clear though, even after 14 days, and even if you had 2 doses on the regular schedule, it's not the time to let go of the public health restrictions. These things work hand in glove. You've heard about the famous Swiss cheese model, right? If you take a slice of Swiss cheese, you can look right through it. There's a hole. But if you take the whole block of Swiss cheese with all those slices lined up next to each other, you can't see through it. Well, the virus is trying to get through those holes, and masks and distancing and vaccines and cutting your contacts are all the slices of cheese that add up together to block the path of the virus. And the vaccine is an incredibly powerful tool, but it's not perfect. And it will never be perfect. No vaccine is. So we still need to be cautious, even if you've received the vaccine.
Okay, let's cut to the chase here. In terms of the population, what is better? To take the doses that we have, which are obviously not enough to give everyone 2 doses as this trial showed.
Or 1. Right.
Is it better to give as many people as you can that single dose, or to restrict it so that you give it only to people to whom you can guarantee that you can give the second dose?
So let's do the math, shall we? I just told you that I think that 14 days after you get the vaccine, we can count on an immunity that approaches 90%. If you look at the trial results, the maximum that they get after 2 doses is 94%. So me giving you that second dose in the short term offers a whopping 4% increase. Now, of course, these are statistics and numbers, and they can vary. And I'm not suggesting these are real numbers we can apply to real people, but it gives you an idea and a flavor. The bang for the buck for giving a person a second vaccine in the short term is 4%. If I give that to a brand new person, it's 90%. So you look at it from the population point of view, you get way more immunity in the community by splitting those doses into 2 different people. Now, there are still concerns that this may mean that the immunity wanes sooner, because as I said, there is a point to that booster. It's important in keeping a long-term response and having a higher, more effective response. So it's not that we should be forgetting about it, but I do believe there's more flexibility. We can monitor this situation. We have data that's coming from countries like Israel that can inform us as to how well this actually works.
Let's talk about the data that came from Israel, because of course it's been all over the news, and they are well ahead of us in terms of per capita vaccination. And they basically have agreed with Pfizer that in return for the supply of the vaccine, they're going to basically be a nation on trial, right? So there are a large number, of course, who have already been vaccinated. And among those, there are obviously people who have contracted the disease in spite of the vaccine. And this is what is making the news. So what do we make of those numbers?
So I've read all of those reports, I can assure you, and given them a very careful thought, because my initial reaction when I saw the headline was like everybody else who saw the headline, oh no, this is going to be a disaster. Well, I got to tell you, this is a case where you shouldn't just read the headlines, you got to read the article, because the data that came from Israel said that at 14 days after the first dose, they were seeing a 33% reduction in infections. Now, just reconcile that with what I just told you, right? I'm not expecting to see anybody protected at 14 days. 33%? I'm doing handsprings. I'm jumping for joy. I think it's absolutely incredible. In the trials, they didn't see that level of protection by 14 days. Somehow, Israel, the innovation nation, seems to have done better with the vaccine than Pfizer did when they were using it. So I think it's really important to understand that. What we need to know now is what happens from day 14 to day 21 or day 28, because that's the period where we expect the vaccine to be working. Will they hit that 90% that we saw when we looked at the data from the trials or not? That's the real data that I'm waiting for Israel to send to us.
What do you think if someone has been vaccinated, in terms of travel? Let's say if someone were to come from Israel to Canada and they have been vaccinated, they got both shots. What should the Canadian government approach be? Should they be made to quarantine for 2 weeks, or they've been vaccinated, 2 doses, 2 weeks have passed after the second dose? What should be our view on this?
Well, I think this is an in-evolution situation. There's the what you think makes sense, and there's do we actually have enough proof that we can rely on it? So obviously what makes sense to everybody is, hey, they've been vaccinated, they're immune, who cares, not a problem, let them do what they want, right? That's the obvious answer. But there's a few things that we need to be a little more clear on before we're willing to tell vaccinated people that they don't need to isolate. The first is, there's still this niggling doubt that people are saying in the news of, does the vaccine prevent transmission? I hate that phrase, because what it really means is, does the vaccine prevent asymptomatic infection? We know it prevents and reduces symptomatic infection, because in the trials, the people who were actually protected were symptomatic people. But what the trials didn't do was go out and swab twice a week every single person who had been vaccinated and every single person who got the saline solution. So we don't know with certainty that asymptomatic infections are reduced by vaccination. Everything we know about vaccines suggests they will be, but we kind of like to know that before we said that that person from Israel is safe to circulate in the community and is not at risk of spreading the disease. And the other thing is, as we were just talking about, we want to know the real life efficacy of this vaccine after 1 and 2 doses, because right now we're working off the trial numbers, and people in trials are not the same as the real life people who get the vaccine. They obviously select for healthier, safer individuals for trials than the real world offers up.
Well, let me bring Jonathan in here, because he's been looking into the PCR test, and there's so much stuff on the internet about this, about how it's unreliable and that cycles aren't right number, and all of this this stuff. So Jonathan, maybe you wanted to bring that up.
Sure. I mean, the issue with the PCR test, which is the standard laboratory test that is being done on those swabs usually that people get to know if somebody has the virus right now, there's a lot of misinformation about those tests. And some people who tend to think that, the COVID-19 is not as bad as people are saying, will often make the point that, well, the CT values that are being used for the test are way too high, and so you're just detecting non-specific stuff, and it's all nonsense. And the real point that I want to make is that those tests, those famous CT values, which I'm not going to get into, but I did write a whole piece about this. It's available on our website. But essentially, it's the number of amplification cycles that are needed until you clear a certain threshold, and you really start detecting the piece of the virus that you're amplifying in the laboratory. That CT value, there's no hardcore threshold beyond which what you're seeing is non-specific noise, et cetera. And the labs that are running these tests have written extensively about these things. And it is, in a sense, quite relative, because not everybody is using the same basic elements, the same reagents that go into doing this amplification procedure, what are called primers and probes, for example. So there are lots of little things that will be different from one laboratory to the next. And the analogy that I use is of chicken soup, which is that there is no one recipe for chicken soup, right? Different families have their own chicken soup recipe. And as long as that recipe has been internally validated, meaning that the people in the family are, very happy eating that soup and it tastes like chicken soup for them, then it's a good functional chicken soup. And it's the same thing with those PCR tests. They are internally validated. There are control samples that are being used in each run. And these laboratories are also externally validated by usually national laboratories as well. So as long as this is being done, and as long as things like pretest validity are taken into account, meaning, the person getting tested, there's a reason why they're getting tested, because if you're just testing anybody, you're going to get a lot more false positives than if you're testing people who have a reason to be tested for this. As long as all of these things are being followed, then the test is actually highly reliable.
Jonathan, there are chicken soups, and then there is my chicken soup.
Of course, yours is the best.
That was the first point I had to make. Is there is a gold standard chicken soup, and that is my mother-in-law's chicken soup for Friday night dinner. That is the chicken soup to which all other chicken soups aspire to be compared.
Of course.
Okay, I take that challenge. Okay, so Don, do you come across this? People are questioning the validity of the test?
I don't think I've seen as much people questioning the validity of the test as really trying to understand what the result means. And this came up really early in the outbreak, right? We had people that had COVID-19. Nobody was questioning it. They were sick. They were admitted to hospital. They were positive with actually what we say is a low CT value, which means a ton of virus around, because there's an inverse relationship there. And what happened is their test stayed positive. And the test was positive at week 2, week 3, week 4, week 5. And yeah, the CT values went up. So we were finding less and less of the RNA that this test looks for, but they were still positive and we didn't know what to do with it. We really didn't know if we should be keeping these people in isolation or not. And in wave 1, there were people that were isolated for 4 and 6 weeks because their tests were intermittently positive. So we now know that actually that what was really going on is that these people are shedding bits of probably dead RNA, dead virus that's stuck up in their cells. It's kind of like, after your cold is done, you're still coughing up green stuff for a week as you clear up your lungs. Only in this case, the green stuff was the virus. So I think we've learned an awful lot. I think most people recognize now that the CT thresholds that we're using to diagnose someone with COVID, saying that they're either on the way up or on the way down, or they have COVID right now, are much more sensitive than diagnosing someone that's contagious. And I think that's actually the next big barrier for us, is to understand, how do we measure people that have enough virus in them that they can actually infect somebody else, versus just, you're a statistic. You either have or have had COVID, but it's a mild case, and it's not actually relevant from an infection control public health point of view. That's where we have the issue with the rapid diagnostics now, and comparing the sensitivity of the rapid diagnostic test to the sensitivity of PCR. I think our feeling is, as you said, PCR is too sensitive for finding contagious individuals. So when we say that the rapid tests find less people, are they actually finding the right people? And they're actually a better measure of contagious individuals. The jury's still out on all of this, but I think that's really one of the big unanswered questions that we need to be focusing our efforts on.
Well, this brings up the other question that is on people's minds, the variant, and that these strains are more contagious. So what does that actually mean on a practical basis? Does it mean that this 2-meter distancing, which sort of pulled out of the air anyway, should that now be 4 meters? Should we be even more careful with wearing masks? Is that what more contagious means?
Look, more contagious, the way I explain this to people, is actually a really simple concept. We always knew, and I've always said, you're not going to get infected with one virus particle, right? A single virus particle landing in your nose, you've got enough basic immune cells that they'll wipe that little virus out, no problem. We don't know what the magic number is. Let's say it's 1 million. That's probably a pretty reasonable number. You got to inhale 1 million particles of virus to get infected. So how do you keep your exposure under 1 million? You keep it under 1 million by being further away from somebody, so that when they breathe out their particles, less of them reach you. By wearing a mask, so that you filter on your end, they filter on their end, and you cut down the particles. Stay outside where air dilutes the virus. And air outside is much more plentiful than air inside. All of these things that we know. So nothing has changed. The game is exactly the same. But maybe now you only need 700,000 to get infected and not 1 million, because these ones are a little better. Does it change the way that you should be behaving? Does it change the precautions? Did you know that if you were standing at 2 meters away, you would be safe at 900,000 particles in your exposure, and now you better back up because you want to get down to, of course not. We're using the exact same precautions. It just means take it seriously because, hey, this virus has just gotten a leg up and our public health precautions haven't.
I'll tell you, it changed I'm doing everything that I should be doing. But I went into a coffee shop the other day and like they have a max number and I keep distance or whatever. But I listen to the daily all the time. And I listened to the daily episode literally like that morning. And I went in there and I started to really like get nervous because even though, and I also wait sometimes for people to continue leaving before I enter. Like I really just want there to be those little people, but someone was, behind me or whatever. And I was like, oh my God, I was like, this is now your mask is 50% less and I'm 50% less than we were before we knew about this new variant. And I I spent too long in there, I felt, and I got out and I was like, oh, that was not a fun experience. Like it wasn't like 4 months ago when I felt a little, I don't know, that I was doing everything. I get it.
Well, look, I'm hoping that, this adds a little bit of spine to some of these recommendations. What I'm sure you've all observed is what I've observed. We all know what the rules are. And I guarantee you that I can easily find someone who can easily tell you the justification for why they can bend the rules because they don't have COVID, the person they're interacting with doesn't have COVID. It's only this. It's human nature. We all want to do what we want to do, and we don't particularly like people telling us not to do it. So we will look for any chink in the armor of the public health recommendations to do what we want. If we have a little more concern that maybe though bending those rules might actually backfire, then maybe that's a good thing.
Do we have enough evidence to know whether or not the vaccine will work equally well against the variants?
So we have some evidence for some of the variants, which have actually been tested, where we've taken the antibodies from vaccinated people and seen if they can neutralize the different variants. And for example, the UK variant, it does look like the antibodies will neutralize the variant. That's still though in the lab, right? That's not the same thing as saying that we vaccinated 100 people, exposed them to the UK variant, and look, it worked. That kind of evidence is really only going to come from the real world. Israel's going to give us some of that evidence, and so obviously is the UK as they roll out their strategy as aggressively as they are in the context of rampant spread of the variants. And again, when we talk about variants, let's just be clear. There are many, many, many variants, and they're not new. They've been here since the beginning. It's normal for a virus to mutate. This one is doing exactly what we expect it to. And it's not doing it actually particularly fast. This is not like the HIV virus. This is not like the influenza virus. This is going at a predictable, slow pace, and one that honestly, I think we're going to be able to deal with.
Another question comes up from people is, okay, I got the Pfizer vaccine and the second dose is not available, but the Moderna is. What do I do?
Yeah, that one is definitely a tougher one because unlike when we talk about the 1 dose, 2 dose, and we can look at real life data from the trials, this one, you're flying by the seat of your pants. This is just opinion, and you know what they say about opinions. Everyone's got them and some other things too. So my opinion on this one is if you actually look at the composition of the 2 RNA molecules that make up these actual vaccines, they aren't very different. And at least if you look at the results of the clinical trials, it's actually quite impressive how the results look almost identical when you vaccinate people with almost identical RNA molecules. So the UK's already done this, right? They've said, we're going to mix and match. It's going to be Coke versus Pepsi. And that's the real difference here. So long as you get a glass, don't complain. So we're going to know. We're going to know what happens in the UK. Is there a compromise? Just to be clear, it's actually possible that it will work better, because we're going to prime your immune system with something and then give it a slightly different variant that's going to force it to really think hard about how it gets those second line responders out there. So it's actually conceivable this will be a better approach. But fortunately, we have several living labs out there that are going to answer this for us.
But
Now,
can
the
I ask you
AstraZeneca vaccine, which has been rolled out in the UK, and it's a different modality, of course, that's a viral vector vaccine. And in the US, somehow FDA seems to be more suspicious of this vaccine. Do you have an insight into that? Why they're dragging their feet, apparently?
Well, last time I spoke to Tony Fauci, it was one of our topics. No, seriously, I obviously am not at the FDA table, so it's very difficult for me to say what the FDA is thinking about and looking about. But let's just be very clear that the FDA has a very different set of rules. It's a very different culture. It's a very different legal climate in the US, and looking at the way that they approve vaccines. Even with the Pfizer and Moderna, obviously they were slower out of the box to approve them. And that's not necessarily wrong. You know, one of the things that people have all expressed concern about when I talk to them about the vaccines is they hate this word fast track. It scares the living daylights out of people that something fast track is going to be shoved into your arm. And I think, to me, the fact that Health Canada and the FDA are taking a little more time on this dossier actually just reassures me and reminds me to tell our listeners that fast track is not the same as shortcut. And we're still using all of the same criteria that we use to approve any other vaccine or medication that we're going to put into Canadians. We're not cutting corners there. We're cutting corners on paperwork, getting the manufacturing up before we actually finish the trial so that we got doses in a freezer ready to ship the next day. All of the things that normally slow a vaccine down that have nothing to do with the actual data, the actual trial, and the actual safety.
We haven't heard much recently about Sputnik, the Russian vaccine, which they actually did publish their data in the Lancet. So, you know, they do have some data, and they are apparently using it in Russia on a large scale, but we haven't heard anything, right? Have you?
No, I have very little insider information on that one too. But I think you know how this is. This is geopolitics meets science meets economics.
Yeah.
I think we can all see what's at play here.
Right. But, you know, I mean, it's certainly possible that they do have something effective. I mean, Russian science is, you know, is pretty good science. So we'll see. Okay. Well, of course, there are many other issues that people are interested in besides the vaccine in terms of treating COVID. And one that has been coming up is the use of a gas called nitric oxide, which has been used previously for various types of lung disease. What is the status of this and what potential is there?
So, you know, nitric oxide is a really interesting molecule to look at because it has many different effects inside the body. It actually is a signaling molecule that we use, our own body uses to tell different cells to do different things. And it has direct effects on killing the virus. So there's certainly some potential there for this gas. The problem is figuring out how do you administer this so that we give it properly, because you know, if you just squirt some up people's nose, obviously giving it in the nose may not treat the stuff that's in the lungs. If you breathe it in, are we getting it at the top and the bottom? Do we get it to all the parts of the lungs? And perhaps much more importantly, does it penetrate right into the cells where the virus is actually causing its infection, or does it just work on the surface? And that's been the concern for a lot of these sort of what we call topical, where you know we're applying something to the outside of the cells of the airways, or inhaling it instead of giving it via the mouth or the vein or injection, where we expect it to get delivered to the cells themselves. So-called delivery issues. So I think that the jury's simply out. It's just very early days. It's one of a large raft of potentially promising molecules that can be repurposed to treat COVID, but the devil's in the details, right? Look at the results that we saw with hydroxychloroquine. Really great reasons to think in vitro initially in test tubes that it would work. When the rubber hit the road, wasn't impressive, and that's why we do clinical trials.
Is nitric oxide being used now by anyone to treat COVID?
So I'm aware of several efforts to study this in a more systemic way. There's several companies that are looking at ways to actually use nitric oxide in various applications, but I'm not aware of any large-scale clinical data that's being assessed right now.
There are also a lot of over-the-counter sprays, you know, for nose, etc., which, you know, have been used for colds and the flu, clear up congestion, etc. But now, at least one of them is this product called X-Clear, which is made of xylitol and grapefruit seed extract. And there have been a couple of papers published, basically case reports of people who have symptomatic COVID and have been spraying this up their nose, and their symptoms go away somewhat sooner, and they have a negative test somewhat sooner. Of course, basically these are anecdotes, but just in terms of general science, the notion of spraying something up the nose to try to control COVID-19, what do you say about that?
Yeah, I gotta say I'm a skeptic, right? You know, the amazing part to me here is that we have people that are marketing aggressively, trying to spray something up the nose to control COVID. And at the same time, half the population wears their mask under their nose because they don't think they need to cover their nose. That to me is the great irony of this conversation, but we'll leave that aside for the second. Look, COVID is an infection of the respiratory tract, not just the nose. The reason people get sick is their lungs are infected and they actually have problems with lung disease. It is really hard for me to believe that spraying something up the nose alone is really going to modify how this works. The reason we use nasal sprays during our colds and sinus infections is we're trying to alleviate the congestion in the nose. We're not actually trying to kill the virus in the nose. We're not trying to cure our nose infection. We're just trying to decongest so that we can talk normally and breathe when we go to sleep at night. I think the other thing that's really important in these studies, and something that people need to be a little critical of when they see it in the newspaper and they hear the study results, is the second point you talked about, where if you spray these things in the nose and then they look for the virus, they find less virus. Well, you know, it's not rocket science to know that if you take something toxic and you squirt it on the surface, it's likely to kill the virus. And then if you go look for the virus on the surface, you're not going to find as much virus. But that doesn't have anything to do with how much virus is living deep within the tissues. You know, to quote the famous ex-president of a very large country close to us, you could probably spray bleach up your nose and you would have less virus. That doesn't mean it's a good thing to do. And let me be crystal clear, I do not recommend spraying bleach anywhere inside your body, including your nose.
So no intravenous Clorox. No
I think that one is not a clinical trial I will sign up for.
Can I ask something? We have, I mean, I have a question myself, and then we actually have one here on the YouTube chat. We could start, since mine is a little bit more along the lines of what we're talking about. You said that a lot of the second boosters, you know, it's a year, right? Even like the flu shot or even every 5 years, you know, when you go to the doctor and it's time for your booster. This one was set at 21 or 28 days. Well, what are they asking? Or maybe they're not thinking that long term. And I believe you got one of your COVID vaccines, correct?
Yeah, right. I'm a healthcare provider. I work on the COVID wards, and I received one dose.
And you don't have a date for a second at this moment. But I wonder, you know, what's the long-term plan? Do they write down your date of first or second vaccination, and then they say, we'll see you next year? Like, what is the plan? Or maybe there isn't one. I don't know.
So there is a vaccine registry, and the results of your vaccine are going into the Quebec electronic medical record. So the data is not being lost. Is it as efficient as it could be with apps and people logging on and being able to get access? Of course not. This is Quebec. We aren't quite where we all want to be, right? But they are tracking this, and the promise has been that you will be called back before 90 days for your second dose, and that registry will be used to call people back for their second dose. Obviously, we will see how well this works. We haven't got to the point where we're ready to start giving the second doses, but we'll see how vaccine rollout, part 2, the sequel, happens when we get to that period. Right.
Okay, thank you. And the second, the question here talks about Hepa filters. It's something I've also been wondering about, even for my house. This question specifically has to do with school boards, how they're rushing to install them, but how effective will that be in preventing transmission in a real world setting? And are they effective? Is it worth it?
So I'm going to pivot on this question, and I'm going to point out that one of the things that I think is the most important responsibility that scientists and physicians and others have in the context of this epidemic is, when you know what you're talking about, speak up, give clear and understandable advice to the population. But perhaps more importantly, when it's not your field and you're not an expert, let the experts talk. Do you know what? I'm not an engineer. I don't know anything about ventilation or HEPA filtration. What I do know could be written on the back of a matchbook. And therefore, I'm going to leave that question to people that actually know what they're talking about.
Fair enough. Good.
The trouble is that there are a lot of people who think they know what they're talking about, but don't really know what they're talking about. Just to get back to the more infectious variants, another question that comes up: does this now mean that you are more likely to be infected by touching a surface? That is, if the same amount of virus that normally would be on a surface from your coughing or sneezing, if it is a more infectious variant, then do you have to be even more scrupulous about cleaning those surfaces?
So of course, theoretically, every type of exposure you have to one of these viruses is now higher risk of transmitting, because you need less of these viruses these virus particles to infect you. So in a pure technical hypothetical way, of course that's true. However, most of us believe that the amount of virus on a surface is so low that even with this boost in infectivity, it's a pretty hard way to infect yourself by touching the surfaces. And rather than cleaning the surfaces religiously, the most important and simplest way is clean your hands. The virus doesn't penetrate your intact skin. If you pick up the virus with your hands from a surface, the way you get infected is when you do the famous this, as I'm doing now, and transfer the virus to your nose, mouth, or eyes. So long as you wash your hands after you touch those surfaces, the virus has no chance of infecting you. And I would say washing your hands trumps everything else.
Okay, now, as we wind things up here, let me ask you a difficult question.
Uh-oh.
Where do you think we're going to be 2 years from now?
Oh, 2 years.
Well, 2 years is an easy one. I thought you were going to ask me where we're going to be 6 months from now. That's the real tough question. 2 years from now, I think coronavirus will be in our rearview mirror. I think this will not disappear. I don't believe we will eradicate this virus. I think this will be another influenza that is a respiratory virus that circulates. There will still be people that die from it, but most of us will be immune or vaccinated, immune from infection or immune from vaccination. And I don't think it will be the public health disaster that it is now. Look, we don't shut down our world for influenza every year, even though there are deaths. They're not anywhere near as many deaths or as much a burden on the hospital system as coronavirus was this time, and that's why things were different. We're not talking about making the world a perfect place or healthcare a perfect system, but we're talking about reducing this to the background level of risk that we all deal with on a daily basis. What I'm more interested to see is how are the rest of things going to change in life? Are people going to start wearing masks when they have a cold and actually staying home from work like we would really like them to? I don't know about you, but I haven't had a cold since March. And boy, I'd really like to keep that going. I don't know, that would just be fabulous. Are we going to use Zoom like this for meetings so that I don't have to drive across town to spend 10 minutes with somebody in a room? I think there's some things we can learn from the epidemic that will actually improve the quality of our lives.
You think in 2 years we'll be at the Bell Center, sitting beside people with—
That's the important question that Joe's waiting to ask.
With 21,000 people there cheering the Canadians?
You are safe, I think, to buy your season's tickets 2 years from now. I'm going to go on record as saying that. Okay, you might also want to buy a mask, though.
That's really what I want to hear. That's really what I want to hear. Okay, because I know you can't predict whether or not we're going to be Stanley Cup contenders, but
yes, I can.
Good chance. Okay, Jonathan, anything further that you want to ask?
No, and I also agree with what Don is saying. It is hard to predict, what's going to happen in the far future, but I do think that we're going to get there. We're going to get back to something that resembles normalcy, and indeed, it will be interesting to see what lessons we choose to remember from all of this and which ones we decide to put aside.
I do think, though, I think that there will be certain industries that do suffer for many more years. I mean, kind of like a post 9/11 PTSD experience. I mean, I don't think flying is really going to be what it used to. I know that airports are packed now, or maybe not right now, but 3 weeks ago when it was Christmas and everything, but it was still high intensity and anxiety. I'm not sure that industry might, I think, take 4 to 5 years to kind of recover in some way. And, hotels and all that stuff. Airbnb might do better because it's individual rentals. And and those types of things. I also read some great articles recently talking about, now that we, like Don, you said, maybe Zoom meetings will increase. And I think there's like a surge in athleisure wear, you don't need to wear jeans all the time, and Lulus and all those other leggings are more work appropriate. But there's also, that's the one side. But the other is, after the Great Depression, there was the Roaring 20s where people said, oh my gosh, now I want an excuse to dress up. I want to go out to the Bell Center or just for a dinner with girlfriends where normally you would bail. Now there's going to be less bailing on plans, because I hope, like Jonathan just said, what we choose to remember, or just being grateful and having the opportunity to go out. I don't know, maybe that will be in 2 to 3 years. I'm not sure if I'll wear a mask when I go to restaurants, but maybe. But I think we may want to just be out and about more.
You're right. I mean, many things are going to change permanently. Conferences, I think, are one, where, why do you need to have people fly from all corners of the world and sit in a hotel ballroom, when you can basically do it as well like we're doing here? Lecturing is pretty good via Zoom. I don't think we're going to go back to live lectures the same way. So yeah, there are changes. But Don, you said the masks. I mean, I think people are learning that masks work. And like we look at Taiwan, where they have a history of wearing masks, and they don't have these epidemics and pandemics. So yeah, it's the old story. If you don't learn from the past, you don't know where you're going to be in the future.
One thing I think we can all agree, however, that we hope will happen is that we'll get our restaurants back on their feet. Montreal has always been one of the dining capitals of the world. I feel for my local restaurants that have taken this horrific hit. And I personally will be out there dining in force as soon as possible to help get those chefs and restaurateurs back on their feet.
Well, I think they've gone overboard with closing down the outdoor dining. I think one can certainly argue for the indoor, but outdoors, the risk is small and the benefits are pretty big, right? So yeah, we got to get back to some degree of normalcy, and you can't live your life evaluating every single minute as, is this risky or not? All of life depends on evaluating risk-benefit ratios.
That's Joe. Joe, you've been saying that way before COVID. Any decision we make.
Sure was. Was.
Well, that brings us back full circle, because that's what we were talking about. This one dose and delaying the second is calculating risk for a potential enormous benefit. And it's actually a bold but following the science move on the part of the Quebec government. I've been very critical of many of the things they've done. I think this one, they made the right call.
Very good. Okay, Don, thanks a lot. I think that was very informative. One last question. In the hospital, are you still using remdesivir?
So it's on our hospital protocol, absolutely. It has a very narrow window of use for a very select group of patients. We're unsure of the benefit, but the downside does seem to be fairly low. So in that appropriate group of patients, we use remdesivir, yes.
Any other antivirals?
No.
No, it's a...
Dexamethasone, of course, which is not an antiviral, and we use that in the ICU. And we also use the newest agent, which I'm sure you heard reported on, which is the antibodies to IL-6, or the receptor antagonist, but the things that block IL-6. And those we use in the ICU immediately when people come into the ICU, because that has also recently been shown to improve survival.
Now, are those readily available?
They are. There is a stock available in Canada, and the federal government is securing an adequate stockpile so that we'll have access to all that we need for the potential ICU admissions in the rest of this wave.
Great. Okay, thanks a lot. That's very informative and entertaining also. And I'll take up the chicken soup challenge.
Once COVID is done, in 2 years, we will have you back on. We'll do the chicken soup challenge. Sounds good.
Okay, thanks very much. And thanks, Jonathan, and thanks, Emily. And we'll be back in 2 weeks with a slightly different format, because we will branch out into a couple of other topics, other than COVID, because we don't want to let COVID totally rule our life. I mean, you know, stuff goes on. There are other concerns that come up in terms of diet and environmental contaminants, and then, you know, all the other things that we normally deal with. So no, we won't totally leave COVID, of course, because it still will be with us. But we're going to transition, and we'll start calling our broadcasts a dose of science.
Exactly. Yeah, those will be released starting next in 2 weeks, Thursday, February 4th, and it'll be up on our YouTube channel. And you can find the link on our website and on YouTube. It'll be publicized.
Okay, thanks very much. And thanks to all of you who have tuned in. And you can tell your friends that this is recorded and they can view this at any time that they want.
Thank
Bye
you.
for now.
Thank you.
Bye.